And we want to welcome all of you to today's presentations. I'm sure we are going to gain quite a bit and learn a lot today. Remember the theme of today, which is, can we read aloud? Inaugural International PPH Conference 2026. And so the theme of today in the morning, the session, is about postpartum hemorrhage. So that's our core business, and we want to change a life every day. And are you committed to changing a life every day? Very good. So to start us off, I think before we begin, I would like to have at least 2 reflections on yesterday. Just 2 seconds reflections from yesterday. I don't know whether someone has a microphone. So a reflection from someone? Dr. Sally at the back.
Good morning, everyone.
Good morning.
I'm the National Secretary, Midwives Association of Kenya. I want to give my reflection for yesterday. One is that from yesterday's activity, I learned that we have a lot of innovative ways that we can be able to stop PPH. However, then we need to look for how we can ensure that we can be able to adopt various innovative ways to ensure that we prevent PPH, and more specifically even to be able to manage if it occurs at our various levels. Another exciting thing is being able to attract a grant. That was a very wonderful presentation, that we have to be very enthusiastic in the process, and eventually not just being able to attract, eventually using it effectively and speak for what you've also done. Thank you.
Okay. Thank you. Thank you so much, Dr. Sally. Those are very key reflections. Any other person with a reflection? Any other person? Can we assign randomly someone? Yeah, I think from our hackathoners. Okay, someone, yeah. Carol?
Good morning. My name is Caroline. Reflections from today. One was from Professor Kihara when she said, take care of your health. They should be in charge of their health. And one was from, I can't remember his name, but he talked about communication, how we should communicate, and we should be actively involved in communication. Thank
Excellent. Excellent. So communication and women taking care of their health, I think that's very key for the women here and even the men who take care of the women. So today, I think it's an interesting morning. We are going to begin with our very key speaker, who is our neighbor from our neighboring country. And he'll be speaking about building effective maternal health workforce, the Ugandan experience. So as he comes, I would like to speak a little bit about Dr. Kayondo Simon Peter, who is an obstetrician and gynecologist and public health specialist. He has a strong SRHR, he's a strong SRHR advocate. He is the vice president of the Association of Obstetricians and Gynecologists of Uganda, and has supported the Ministry of Health Uganda as national consultant in development of maternal health guidelines. Let's clap for Dr. Simon Kayondo as he shares his experience.
Thank you very much, Dr. Eunice. I'm happy to be back here. Nairobi is probably one of the places I am most outside my own country. So I'm happy to be back here, and I'm happy to stand in front of you. We are very happy with especially COGS, because it's through COGS that we established these relationships that we continue to cultivate up to today. So that's my name, and I serve as the Vice President in the Professional Association of Obstetricians and Gynecologists of Uganda. I bring you the greetings from our society. Most of what I'm going to speak about is spearheaded by the Ministry of Health, so I also specially recognize them. So Uganda has made progress in the last 5 years. Our last demographic health survey was done in 2022. We're actually about to have another one. But between 2016 and 2022, we had a drop from 336 maternal deaths to 189 per 100,000 live births. So we've made significant progress. We also have some preliminary results that indicate that we are likely to hit at least about 100 in our next demographic health survey. So we think by 2030, it's very likely that we may get close at least to that target. However, unfortunately, postpartum hemorrhage remains one of our critical causes of preventable maternal mortality, contributing over 40%, probably not very different from what we have in the rest of the region. We've therefore prioritized evidence-based interventions to prevent, diagnose, and manage PPH timely. We are thankful for the collaboration, a very good one, between government, development partners, professional associations, notably the one of obstetricians and gynecologists, as well as the one of the midwives and nurses. That's simply a pictorial indicating the large chunk that hemorrhage puts on our maternal mortality. This is a picture from last year when we joined a multi-country effort to end PPH through various activities. We held a CME at one of our biggest centers, the Mulago Specialized Women's Hospital, and thereafter we had a short run. We are happy to go again this year. And we are happy for the involvement in the NPPH effort. Everything I'm going to speak out is after that event, actually. So in October last year, we know the new updated guidelines for PPH were launched at the FIGO Congress. And Uganda had a few champions there who therefore led the effort, starting with November, to have a national adoption and adaptation. In November 2025, we had Draft 0 completed. In December, we had the WHO and Ministry of Health Champion Development Workshop, and we had Draft 1 finalized, which we then went ahead to validate in Feb 2026. Between March and June, we embarked on trainings using the updated training materials based on the updated guidelines. And we had a batch of national trainers, and we also had a number of frontline health workers, starting with the high burden areas with PPH, and that is the Kampala Metropolitan, that is actually where most of the bad outcomes happen. This is mostly because I think many of the biggest referrals are in this area, but also we have some areas like our eastern area of Busoga, where there are very, very high numbers of PPH deaths and generally maternal deaths. So we train national trainers, and then we embarked on a number of champions, practice coordinators, and in May 2026, Uganda, became the first country in Africa to zero price 15 life-saving commodities at all public facilities. And that includes these key commodities: tranexamic acid, heat stable carbetocin, and oxytocin. Whenever I praise my country, I'm very afraid because I know a few others may come and say, no, we've already done this, but we are sure we were the first. Yes. So the national TOTs were based on our local maternity neonatal systems. We have about 16 in the country, cropped out of the different regions. And the local maternity neonatal systems are led by gynecologists and midwives. So it is confirmed, therefore, that when you do training, you are sure that the cascading will happen down to the last health provider, as well as providing good leadership. So thus far, we've at least had about 88 TOTs and 47 champions. And especially to mention, there are midwives and obstetricians, medical officers, clinical officers, but a cadre that we've brought on board very recently is the anesthetic officers and the anesthesiologists. I don't know how you work with them here, but before we thought of involving them, you know, you have PPH and the anesthetic officer or the anesthesiologist is not helping the team because they feel like, well, this is obstetric business and there is little contribution I have to make. So we brought them on board all the way from the pioneering team. So in total, we've had about 200 trained. Of course, looking at the time frame, this is a significant number. And among them, we have the champions and the practice coordinators. Maybe I want to say something about practice coordinators. These are very interested people. They don't necessarily have to be the highest ranking individuals in the facility, but they should be very interested, knowledgeable, skilled, and willing to carry on the trainings and mentorships and audits within their facilities. Most of the trainings of frontline health workers have been provided in facility. So we are able to sit with the providers, understand their challenges, but also support them on carrying on continuous trainings and drills and so on. So far we have about 67 champions through the cascading of these trainings, all done by June. We are also conducting low dose high frequency trainings, and this is mostly led by the practice coordinators that I spoke about. So what happens is they keep looking at critical areas of PPH and having their teams in the different facilities practice one at different times, but recurrently, so that there is no decay of knowledge and skills. So like I talked about the essential commodities, they are now available everywhere: tranexamic acid, heat stable carbetocin, and oxytocin in all public facilities at the very least. But also we've had a number of calibrated drips distributed, and also non-pneumatic shock garments. We've also innovated around making our own calibrated drips through utilization of the companies, for example, that make these Cavera polythenes. They have a way of working around the drips that they have suggested. We are still waiting for approvals. Some innovations is we've taken tranexamic acid off our emergency cuts and created special areas for it. I don't know how it is here, but In Uganda, they've been injecting it intrathecal in place of bupivacaine, because I don't know what happens, but we've had a few unexplained deaths after spinal anesthesia. Then there are convulsions out of nowhere, and then there is a mortality. So we've noted that they are using tranexamic acid in place of bupivacaine. So we've taken them off the emergency cuts and created special areas for them. Of course, we are disseminating guidelines on flyers. We've digitized the PPH materials. And then, like I said, we are really prioritizing low dose high frequency trainings in the facilities, because it reinforces skills and knowledge, and also retention of the same, as well as ensuring facility-based learning. What we want to work on going forward is orient tutors on updated PPH guidelines, integrate these new recommendations into our maternal newborn clinical care guidelines, which is the primary guideline for care of all maternal health conditions, strengthen mentorship and supportive supervision for PPH service delivery, scale up and institutionalize low dose high frequency learning sessions. We want to conduct a campaign, awareness campaign for PPH in September, and we hope this time our run for NPPH will be more structured and better prepared. In fact, they sent me here and said, go get a plan. Told them, just hang on. When I return, I'll have a clear plan. And then, of course, we will commemorate the World Postpartum Hemorrhage Day on 5th October. We want to finalize and disseminate our revised PPH intervention framework, review and update pre-service and in-service training curricula, strengthen documentation, data quality, but also use of data. Data from facilities is generated but never used to improve the state of affairs. We want to evaluate our PPH interventions, because we, for example, have noted that sometimes you save a woman from dying from PPH only for them to die from sepsis, created by your intervention. So we want to see what actually we are doing. Are we making things better or worse? Then we want, of course, to monitor the utilization of these new products, tranexamic acid and heat stable carbetocin. Finally, I thank those partners, but especially Ministry of Health and World Health Organization. Thank you very much.
Thank you very much, Dr. Simon, for that very nice illumination on what is happening with our neighbors. So from Dr. Simon's presentation, I think we'll just begin with our today's presentations. Kindly keep your questions. Keep them, pack them a little bit. We'll be able to review them after the presentations, kindly. Kindly let's welcome Nanma. Nanma, karibu sana in Kenya. Yeah.
Thank you so much.
Okay. Mm. Introduce yourself.
Sure. Okay.
Okay.
All right. Good morning, everyone. I am Nanma Kankum. If my outfit hasn't given it away, I'm from Nigeria. So I'm here to speak about some early results for some work we're doing, comparing the outcomes using different heterotonics, as well as some of the cost consequences that health providers on the front line have to go through in terms of decision makings about medicines to use for PPH prevention. Before I start, please permit me to do two things. One, appreciate the conveners of this conference. I firmly believe that conversations about Africans should be curated, convened, and championed by Africans. And I see the vision for this conference. Thank you very much. And I hope that it continues to grow into something bigger. Secondly, is to appreciate all the innovators from yesterday. That was very inspiring to see. Experts in this room saw your work, thought you had a good idea, and brought you here and you shared, and I think it's definitely appreciated. I think you should not stop. Whatever the outcome today, please, you've already won, and keep doing it. So my work is situated in Nigeria, where, like most other African countries, the burden of maternal mortality is significant. Nigeria contributes one of the highest globally. PPH contributes up to 22% of maternal mortalities in Nigeria. Several efforts have been made actually to improve this, adopting emotive, introducing heat stable capitocin. Nigeria launched its first national PPH guidelines in 2024, which mirror some of the recommendations from WHO and FIGO, especially around the recommendation to use heat stable capitocin where the quality of oxytocin cannot be guaranteed. And while we were very proud of that, one key thing we kept wondering was where the quality of oxytocin cannot be guaranteed. Who determines that? Is it the clinician on the front line who is overburdened? Is it the procurer of the medicine? Is it the regulator who should check but often is not equipped to do that? So as part of our work, we thought we could contribute to the body of evidence that starts to make that very clear. So as part of our project, we went back to look at some of the real world outcomes with different uterotonics and how the PPH incidence was. So we conducted a retrospective study over a few months across over 300 facilities, reviewing over 88,000 deliveries in the facilities, went through very specific patient level data for about 3,000 deliveries where a calibrated drip was used to objectively measure blood loss, and then try to measure a few outcomes, including PPH incidence, severe PPH, the use of additional uterotonics, and also other adverse maternal outcomes. And so the results were staggering, as you'd see. In our context, HSC had the lowest associated risk of PPH compared with oxytocin. The incidence was about 4% compared to about 10% for oxytocin alone and about 8% for oxytocin miso combination, which starts to show you the difference between the RCTs and those control trials, like the champion trials, versus the real world settings. And it's by no means a surprise. It's not a surprise at all. A study in Nigeria showed that over 70% of the oxytocin in the market was below the quality standards. But these are products that are approved by the regulator, that have been procured by government entities, and have been delivered to clinicians at the front line. So by any metric, you should assume it's of good quality, but then it's really not. The dosing patterns also start to reveal something. So while over 52%, or rather 52% of women received the recommended 10 international units of oxytocin, we had up to 40% of cases where double doses were administered, and in up to 7% of cases, quadruple the dose administered. A number of things could influence this, but we also think this points to the level of confidence the clinician in the front line has in the ampoule in their hand. So in many cases, they have to double doses or triple or quadruple to get the results. While for stable capitocin, this was not really seen. Additional use of uterotonics as well, blood transfusion, adverse maternal health outcomes. We increasingly saw or continue to see better results with heat stable capitocin compared to the other outcomes. A second dimension that certainly affects the use of capitocin in Nigeria is the upfront cost, where a lot of people pay out of pocket in Nigeria. The price of heat stable carbetocin, thanks to the access price by Fairings, is about a dollar and a few cents when you factor in markups to the last mile. But you would also find oxytocin under $1. So when a clinician is faced with someone who can't really afford medicines, they then prefer to prescribe oxytocin or misoprostol. But then when you factor in the long-term cost of using a poor quality product, so blood transfusion in many cases where there's still blood loss, the additional heterotonics that you would need to apply, we start to see that the costs begin to compound, and it might be better at the upfront to just use a single ampoule. Additionally, and this is my last slide before I conclude, we start to see that if you then apply just those individual costs and then start to scale up, you could then see significant savings for the health system. We project, and these are quite conservative, that if you use heat-stable carbetocin for up to 75% of deliveries in Nigeria, you then start to save up to about $2.7 million annually for the health system, but also families who often have to pay out of pocket for some of these health costs. So in conclusion, we start to see the benefit and how real-world studies can complement global research and randomized trials and things like that, but also the potential to help governments make stronger recommendations where it's obviously very necessary. So in a place like Nigeria, it might no longer be enough to say where the quality of oxytocin cannot be guaranteed. We might need to be firm and say HSC should be our first line. And we're trying to use some of these results to convince our policymakers and other decision makers in terms of the value. So thank you so much for listening and for your time. We've actually published an opinion piece in one of our national dailies. If anyone's interested in reading, please scan the QR code. And once again, thanks for the opportunity.
Thank you so much, Namna, for the wonderful presentation and showing us the comparative analysis in terms of cost and effectiveness of uterotonics. So our next presenter is none other than Senna Florida. So Senna, kindly take it up and do the honors of introducing yourself. Thank you.
Okay, thank you so much. All protocol observed. Good morning. Yeah, allow me to be on the stage this morning and present preventing maternal deaths from postpartum hemorrhage from Narok, and narrowed to one of the sub-counties in Narok, that is Transmara East sub-county. And this was an evidence-based intervention in Transmara East, Narok County, that is in Kenya. And for the Narok County government, in front of you is Florida Sena, the sub-county reproductive health coordinator, who is going to do the presentation. And the counterpart is from the AMREF, and will really acknowledge. And the PPH, that is postpartum hemorrhage, I'm going to look at globally and nationally and up to the local part of it, that is at the sub-county level. So postpartum hemorrhage remains to be the leading direct cause of maternal mortality globally. And in Kenya, PPH represents a major disproportion contribution to preventable maternal deaths during labor and delivery. For the localized, that is the sub-county action to reduce high maternal mortality rates, Transmara is sub-county designed a targeted facility-based intervention strategy, which focuses on transformation, early identification, and clinical response, quality, and standard obstetric pathways. So we had a retrospective clinical audit. We have 21 facilities in our sub-county, of which we had the intervention evaluated, which is done routinely, during maternity across the entire sub-county within the 21 facilities. The project tracked the total births, that is the PPH case active prevention, strategies, the clinical pathways, maternal outcomes over 12 full months. And for the clinical pathways, we encourage our healthcare providers to identify early PPH and be able to identify if it is the causes either uterine atony, trauma, or thrombin. So within the 12 months, we were able to do the routine data quality audit. You can see we had members, the sub-county level and the partners doing the DQA, going through the registers, comparing the source documents with the reported MNCH indicators, facility staffs receiving mentorship, and this one has really, we've really had this within all the facilities, which has really helped us in managing PPH. We also had verification because all the mothers who deliver in maternity are supposed to be tested for HIV and PMTCT, and all were done within the 21 facilities. For the system evaluation timelines, we had one, the initiation, that is retrospective review, launched, which was baseline data, structured, established across the 21 facilities. And we had implementation, which was rolled out standards, that is the AMSTIL and evidence-based emotive bundles. So our staffs and the healthcare providers are able to manage these mothers using AMSTIL method and emotive bundle. And we really want to appreciate the emotive bundle because it has really made our mothers to have 0 maternal deaths. For the quality audits, we have continuous clinical monitoring of birth attendance, monitoring drug supply security by making sure that we have all the drugs, that is the oxytocin, misoprostols, heat-stable carbetocin, and tranexamic. For the final review, we had completed the study, which the period from full year, that was from June last year to May this year, and have a documented 0 maternal death, which was achieved. For the clinical outcomes, you can see the total deliveries. We had 3,321, which is 100%. For the safe deliveries, we had a percentage of 99.6%, totaling 3,300. And reported cases of PPH, we were at 0.36%, with maternal 0%. Out of the 3,321 monitored facilities, the 12 PPH cases occurred incidents. This was due to standardized care, and all cases were resolved successfully, and our mothers went home safe and their babies. So for the monthly PPH cases, we had one cases until March this year. And I thought of having this abstract because after noting that I had 5 PPHs on March, I had to dig down what could be the reason why this PPH occurred during the month of March. And the reason that I came up is we had first delays, that is right from home, and most of our mothers who came had anemia, and those were some of the predisposing factors that made us to have the 5 cases of PPH. So we had the strategies. We went back to the community, and we had a discussion, thorough discussion, and all our CHPs, that is the community health promoters, were encouraged to have to map up all the women who are pregnant and get to let them come to the facility. And they were motivated by the facility because we have share reimbursement. And the CHPs actually were really motivated to escort our mothers so that at least we avoid all this PPH. For the safe deliveries, you can see the graphs. The trend actually was not badly off despite the month of March, which we had 5 cases of PPH. So for the intervention, AMSTIL implementation has been key. Actually, what we are doing in Transmara East is we have to go down to our facilities and do on-job training to our staffs on management of our mothers using Amstel implement. That is routine deployment of active, management of third stage of labor, protocol for all facility staffs and facility birds, which guaranteed the immediate administration of standardized, high-quality prophylactic eutotonic medication post-delivery. We realized in our sub-county, in terms of SHA registration, we are doing pretty well, and we've not run short of any uterotonics drugs, because whenever we get short of from KEMSA, we encourage our staffs to buy through the SHA reimbursement. So for early identification, that is for the emotive approach, by utilizing PPH, standardized, calibrated delivery drips, we receive from KEMSA, and for the facilities which are not able, we make sure that they procure or they have them within reach in the facility, so as to measure the blood loss after every delivery for the quality blood supply accurate. For the implementation of standard rapid first line therapies administered as coordinated care bundle. For the system capacity, we've ensured that there is midwife mentorship, which is continuous, that is for the skilled birth deliveries, uterotonic supplies, that is the security. We make sure that each and every facility, right from level 2 to level 4, because we don't have a level 5 in our sub-county, but we've ensured level 2s, level 3 have enough uterotonic supply in terms of life-saving. For the facility readiness, strengthen clinical emergency trays. So you find even at the dispensary level, we've encouraged all our healthcare providers to have the emergency trays, which are standardized in response of the obstetric emergencies. So for the community facility-based communication, community health promoters conducted extensive household tracking and sensitized families on danger signs of pregnancy. For the emergency transit coordinations, which created structured rapid transport communication. Most of our mothers at times, they say we are coming from far, no transport, but through the help of the community health promoters, we've enabled this happen within our sub-county. Promoting facility delivery successfully has reduced the risk of unsupervised home births by channeling mothers to skilled birth. So we encourage mother companions, of which we initially were called the traditional birth attendants, to escort these mothers to our health facilities to avoid home deliveries. So in conclusion, consistent evidence-based PPH prevention protocol effectively secured a low PPH incident of 0.3% and 0 maternal deaths among 3,321 deliveries. Sustained the county and partner investment in skilled midwifery and robust logistics and life-saving drug accessibility are vital to lock in the scale this historical sub-county outcome. So thank you, and the motto of our sub-county is no mother should die out of PPH. Thank you.
Thank you. Well done, Zena, for that wonderful presentation from all the way from Transmara. Well done, Team Transmara, for the good job, and you're just right on time. So we welcome Dr. Gulavi to do his presentation. Kindly introduce yourself first.
All right.
Thank you.
Hi, everyone. Thank you. First, I must acknowledge the organizing team. I really like this idea. It's brilliant. The courage to bring people together and sit in one room to discuss this. If for nothing, I think you have touched me, and I'm sure we will touch the mothers who we are managing. My name is Dr. Gulavi. I'm a gynecologist, and together with Joyce and Professor Obimbo, we have a very simple concept. It's nothing groundbreaking, but we believe that this is something that might change the way we manage our PPH. Tell your neighbor, we want to flatten the hierarchy. Flatten the hierarchy. We work in a discipline that has a lot of hierarchy. The intern, then there is the midwife, then there is the MO, then there is the registrar, then there is the then there is the senior consultant who does not, who cannot be touched. Sindio? And so we sat down and realized that PPH is not simply a bleeding problem. It is a teamwork problem, okay? Clinical drugs and skills are not the only missing link. In some places they are missing, but that's not the only missing link. We have issues with delays in recognition and communication costs lives. And we have a big issue of hierarchy and low psychological safety, which silences the first voice. That first voice is silenced, okay? Because they know that the last time I called this person, they really made noise at me. So, tusimpigie, let's not call him too fast, okay? Let's manage. So we realized that we had a starting point. Bleeding was being managed, but delay was not, okay? Mothers are being managed, PPH is being managed. But there is something that we realized, that blood loss was being noticed early but voiced late. Sequential calls were going up the chain, not a coordinated response, okay? Handovers were unstructured, okay? For those who don't speak Kiswahili, there is something called patient hakai poa, okay? The patient is not looking well, okay? That's not communication. So handovers are unstructured. Blood bank is informed as the last person, okay? So when you call that person, you say, where is the blood? The blood bank is telling you which blood, okay? And then midwives and generally anyone as the first voice hesitates to escalate above the registrars. And so we realized the clinical response was really wrong. It was actually a timing issue, okay? So what did we say? We said we'll do for those who are familiar with RCS, or there's something called a fishbone or an Ishikawa sort of diagram. We look at people and culture. We have a hierarchical deference. There is a fear of speaking up. We have a loss of psychological safety. The last time I spoke up, I was really told very bad things. We have a communication problem. There is no structured handover, okay? We have an ambiguous language is being used, okay? You say moderate PPH. There is no such thing as moderate PPH, okay? PPH kidogo, all right? We have sequential and not parallel communication. In terms of the process, we have no transfusion protocols. We have unclear escalation triggers. We have ad hoc role allocation. In terms of teams and roles, we have unclear leadership, silo working, everyone is working on their own. No cross-cadre simulations, okay? When we do our simulations, it's only the midwives alone, consultants alone. We have high workload, night shifts, distance to theater and blood bank. In terms of systems and supply, we have slow blood product turnaround. Blood bank is not part of the team, and we don't have something called a shared mental model. And so we set out to say, what can we do? What's our aim? Can we reduce hierarchical barriers and escalation delays in PPH management by embedding human factors into everyday emergency response? Can we do that? And we really had very simple objectives. Can we improve early recognition and escalation of PPH by any team member? Can we standardize multidisciplinary communication with SBA and defined roles? Can we integrate blood bank into the simulations as well as our management? And can we activate something called a massive transfusion protocol? Can we build psychological safety? I think that's one of the most important things, so that every team member can safely raise a concern. I wouldn't say that we have all the data. We are still finalizing on the data. So some of the work I'm giving you has not been, we haven't done granular assessment, but it was sort of a pre and post quality improvement. So what we saw, and then what we did, and then what we are seeing now. Our unit is Avenue Healthcare. It's a busy unit, not as busy as some of you, but it's a tertiary maternity unit, a level 6 hospital. So what was our change journey? We saw the system as it was. So we mapped the process of PPH events, how care is being done at that point, and then we built a bundle. Okay. So what we did is we came up with something called an Every Voice Counts Safety Bundle, where we look at structured escalation pathway, SBAR training across all cadres, massive transfusion protocol, which was written and agreed by everyone, and then a multidisciplinary simulation. So we involve everyone when we are doing all our things. And then we make it a culture, and the culture is structured debriefs. We have blood bank joining the maternity. We have a maternity users committee. And then we have something called continuous audits and refinement. So we always look at what we are doing and what we are doing well. And then we are flattening that hierarchical cultural. It becomes a normal thing. So when we say every voice counts, we are looking at any voice that can activate the response. Communication is a device, not a mood. It's not, you don't feel like communicating. It must be communicated in a certain way. We use SBAR. SBAR means situation, background assessment, and recommendation. And we use closed loop management of this. Blood bank is actually inside our team. All right, so they are part of our simulations, part of our maternity users. They understand what we are trying to do. So prong 1, structured escalation, SBAR communication, role clarification, massive transfusion, multidisciplinary simulation, structured debrief, as well as embedding psychological safety. So for those who are familiar with memes, then they say, there's a meme that says, "He hi Bambi." All right, so we are moving away from this one. So we are moving away from traditional hierarchy, which is midwives identifies the PPH, delays a bit, calls the registrar, who delays a bit, registrar reviews, delays a bit, calls the consultant comes, then eventually blood bank is finally involved. We are moving away from that to any team member activates the PPH code is activated, everyone is informed at the same time. The theater is informed, blood bank is informed, consultant is informed at the same time. Have a team huddle, then manage the PPH. Okay. Some things that have shifted, people have started speaking up. In subsequent, hopefully in subsequent conferences, I'll do the granular work of saying how this data we have collected it, what assessments we've done. But from the initial assessments that we've done, people have started picking up before deterioration. We have an increase in psychological safety across cadres, all right? The response has become structured, parallel, and rehearsed. So by the time someone is calling, they are saying, this is the situation. We have a PPH, blood loss of about 1,200. This is the assessment. BPs are low, tachycardic, and this is the by the time you're communicating, it's very well structured, and care has reached the mother earlier with fewer delays. Some of the comments I get from the staff that we work with, the midwife would say, before I used to wait to be told what to do. Now I know that I can call the consultant myself and no one will be upset. All right. The blood bank says, in the simulations, we finally understood the clock that the mother is on. Okay. We stopped being a room down the corridor. Right? So they understand that they are actually part of this team. All right. And then the debriefs have made it easier to say that I missed something. And that is when we started learning as a team. All right. Finally, some of the lessons that we've learned. Fix the culture, not only the protocol. SBAR turns worry into action. Okay. Simulate with the whole team, or don't simulate. Parallel always beats sequential by all means. And debrief at every event. The system will improve. Finally, I say this. Culture is a clinical intervention. When every voice can escalate, every mother is safe. And then, so those are some of the recommendations. But what I wanted to say is the most important intervention that I think we've made was giving every team member permission and confidence to speak up. Thank you.
Every voice counts. I think that's the most important thing, and I love the way you've really highlighted hegemony and how it can affect management of clients in healthcare system. Thank you so much for that. Our next presenter is none other than Melanie. So Melanie Olum, will introduce herself, and she's just confirming the time. Thank you.
Great.
Thank you so much, Melanie.
Is it me who's missed something? Oh, okay, that's fine. Good morning, everybody. Are we well? Yeah, well, you do look good, quite attentive. I find this a bit of an oxymoron because Daktari has come and spoken to us about breaking the hierarchy. And unfortunately, I'm here to remind us a little bit about hierarchy. But in the same spirit, giving us confidence that you can move beyond hierarchy and by applying certain principles and strategies around advocacy to get us to the point that we want to be at, okay? So as Eunice had mentioned, my name is Melanie Olum. I come from the International Center for Reproductive Health. That's this one here, okay? And the font looks a bit strange. I think sometimes when you're working with graphics, things can change, but I'm here to talk to us about the possibilities of catalyzing political commitment around financing and supporting all our efforts in ending PPH, okay? So I echo the sentiments from my brother from Nigeria. I don't want to butcher your name, so I'll just say my brother from Nigeria. Yesterday, some incredible innovation was put before us, exceptional work. And I kept asking myself, how is this going to be funded, right? Did we all ask ourselves that question? Yeah, how is this going to be funded? It would be very sad if these very nice ideas go back to the shelf and, you know, you wait for the next time a donor will be around willing to take up these initiatives, isn't it? And we remind ourselves in that space, then therefore, politics is relevant. And that's why I went back to the question on hierarchy, right? We need to get to a point where we are able to convince our leaders to finance these initiatives, to embed them within policy and to make them more sustainable, right? And that's what, as an organization, together with 11 other incredible partners, have been working on for the past few years. Many of them are here, from Professor Kihara, Dr. Bridget, Professor Obimbo, and a few others spread across different thematic areas. So right from academia, from media, from community, and collectively share a vision on how we can advocate for our mothers who might not necessarily have their voice of their own, okay? And that's what we've dubbed Okwa Mama na Mtoto Initiative, loosely translated to Save the Mother, Save the Child. So I'll skip through the burden of PPH. I think that's something we've spoken to very deliberately yesterday and today. But what we're saying is that PPH is an issue, granted, but is it possible for us to get this financed? Is it possible for us to move together as a group of people who are sharing a similar vision and at the same time provoke the political angle behind the financing and policy conversations? As a consortium of 11 partners, we've adopted what we're calling the smart advocacy approach, which is not new to us, but it's just a matter of being very intentional with what you're requesting for, right? What we often call the advocacy ask, okay? So if today, for example, our nice team from Binti, was it called Binti yesterday? Team Binti, are you here? Very nice, okay. So if we were to get any of you quorum with maybe Governor of Nairobi, he seems very approachable in many cases, right? What would you say is your advocacy ask? And I know yesterday a few people asked the same question: what exactly is the problem that you're seeking to address? And in that sense, what are you asking them to do, okay? And is your initiative and your request measurable, right? Is it achievable? Thinking about questions around the financing cycle, right? You target very specific timelines and very specific windows of opportunity to push decision towards a specific direction. So with OMI, our goal is oriented around improving opportunities for domestic financing, encouraging adoption of best policies, and also making sure that the policies are delivered to the ground. We are covering a total of 11 counties through our partners, as listed there. And we have adopted what we are calling the 3-tiered advocacy strategy. So looking at the political level, coming up with advocacy documents like policy briefs, advocacy memos, presenting them to decision makers, key decision makers, right from governors to assemblies. And a strategy that we've also used that has proven to be quite beneficial is using first ladies as champions. This is not new, right? We've heard of multiple projects that do the same thing, but we've been able to see some significant outputs based on this. And then also leveraging different coordination platforms. So right from your TWGs, your steering committees, and provoking conversations around PPH. But we've also not forgotten the power of media and what media can do. I'm happy to know that we have a number of media houses with us this morning. And over the years, from when we commenced towards the end of 2024 to now, we've been able to produce over 60 media features. Of course, with the collective efforts from our different partners, but also boosting public conversation and accountability. Something to remember is more often than not, we tend to think that some of these decisions can only be made at very high levels. But you as people and citizens have a voice, a very strong one actually, right? Voices that cannot be ignored. And you could pose yourselves as a very intentional tool for public accountability, depending on how best you position yourselves. And those are some of the lessons that we've learned over time. And then moving lastly to the last level, which is community level. So again, social accountability forums, also posing opportunities for cross-county learning, as I had mentioned. We're working across 11 different counties, but all with the intentional goal of creating an enabling policy and financing environment. So what have we been able to see over the years? Oh, this font is killing me, but it's fine. So we've been able to see conversations around maternal and child health, specifically PPH, move from a position of low visibility. And I think in the last year or so, we've been seeing a lot of stories in the media, not necessarily entirely credited to OMI, because we also appreciate multiple other partners are working in a similar space. Again, speaking into the efforts and the possibilities of coordinated work around this conversation. We're also seeing partners moving together as a collective. We're seeing systems being strengthened. We've been able to witness what's happening in the different counties, some of which were placed, but even beyond. We have been able to see champions placed at the highest office, crowning the governor of Kilifi, for example, as a champion, First Lady of Kakamega, and at the very bottom, not a very clear image, but through efforts of Professor Kihara and the team from COGS, bringing on board the county government of Makueni to the government level, the governor's level, and positioning him again as a champion, which he's been able to also depict the mileage and the progress that Makueni has made in the space of maternal and child health. We're also seeing that coordination was our superpower. This is not work that we're doing alone. We're working with very intentional entities as well, including the Ministry of Health, the Council of Governors, very strategic. And these are just but a few of the success that we're able to see across the different counties, right from increased financing in counties like Bungoma, Migori. Might not be very clear, but I think this is something we can share thereafter. Kilifi, conversations around even advancing budget by about 11%. We're seeing investment in terms of human resource, which again we've acknowledged is a big challenge in this space. And these are just but other specific, more intentional county profiles around what is being done as far as the referral systems. We've been able to get quorum with the governor of Kakamega, and he's committed to things that go a long way, for example, procurement of ambulances, and also, re-establishing the ones that have been domiciled, investing in specialists, etc. Garissa, also one of our strategic counties, also positioning conversations around ASAL, have been able to move priority of PPH beyond just the health department, but to formally endorse it within county assembly priorities. And I think this was a very big win for us, even as we advocate for increased financing. And to culminate this all, I know that we have seen the Ewene that was launched, and this was a very big achievement and a big showcase of what it means to move as a collective. Because if you can convince the president as a team to prioritize issues that we've spoken about yesterday and today to the point of policy direction, right? And a 6-month commitment to show change across our counties and translate that to national budget. I think that was a big, big win, okay? So it's possible, right? And many people have worked towards it. And I think the trick here is to just keep pushing and to keep tweaking and to keep insisting that we're not just leaving it at the point of commitment, but also encouraging issues of measurement and accountability, okay? Right, so again, also not forgetting the space that community holds, very integral to being part of the conversation. So reaching out to champions at community level, working with your CHPs. Yesterday, Professor Kihara spoke to us about the work she's done with border riders as well. Also very strategic as part of the conversation. And we're also looking at advocacy from a pre-service point of view, okay? So not addressing issues once we are in the hospital rooms or the theater rooms, for example, and seeing how best some of these guidelines that have been so intentionally thought through can be embedded within the pre-service curriculum. And this is work that we're doing with KMTC. And so far, we've been able to advocate for the revision of the nursing curriculum, and we're at the point of validation and pilot. And I think that this can go a very long way in terms of including nuances and innovations like OPOCAS. And then there's the PPH school, which I don't want to speak much into because I know, Prof, this is something you're very passionate about. I usually say you're the resident Gen Z when it comes to OMI. Yeah, you shock us with technology every day. So I think this is also a very important tool that through Prof and his team have been able to generate conversations around, again, what does it mean, what does it look like to convert our students as advocates and to also leverage innovation as a key tool in pushing for some of these changes around improving PPH prevention and management. So in conclusion, OMI, like many other advocacy efforts, are replicable. It just takes intention, it takes strategy, and it takes structure. So what we're saying is practical lessons that other countries can adopt possibly is invest in champions who can convert political goodwill into sustained ownership. Pair national advocacy with county level accountability structures. So don't just leave it at the top level, but make sure it actually cascades down and target your decision makers at county level as well. And then not forgetting the space of data, media, and opportunities for learning so that we can sustain momentum beyond a single funding cycle. And that's OMI in a nutshell. So it's funded by Gates Foundation. ICRH is placed as a lead, but I will not forget the excellent work that our partners are doing. And by exhibition, we're looking at Ushiriki Wema, Options, KMTC, as I had mentioned, Luala doing incredible work within the community, Wanahabari in positioning the stories and media conversation, women engaged in development, of course, and the reminder of what putting out knowledge products looks like, influencing policy looks like, COGS, not to forget Fountain of Hope, Shina Foundation, Fanikisha, and Touch a Life, which is stationed in Kakamega. So everybody here has a respective space where they're advancing the advocacy conversation. So yeah, I apologize for the font. I hope it was still visible in its own way, but thank you so much for giving me your time.
Yeah. Thank you. Thank you so much, Melanie, for highlighting the role of smart advocacy and also the role of different people, using several people and having different voices in different corners. So our next presenter is one young doctor, Fred. So Fred will introduce himself as he takes the stage. Thank you.
Hi guys. Morning. So before I begin, please don't start the clock, just a minute. I want to take this just 30 seconds to say that I really appreciate the organizer of this conference for this opportunity. for giving us an opportunity to present what we have, to showcase what we have, what we've learned, and also to teach each other. So at this point, please help me just to appreciate all of you, all the organizers and everyone for being here. Thank you. I'm very passionate about point of care ultrasound, and my predecessors just come here to talk about point of care ultrasound. And I look at it as one of the avenues that we can use to intervene in preventing PPH and saving mothers. And in the background, we are working and we are advocating for it to be part of the e-motive that is being driven. Areas be just to tell you, sorry for that. Just to tell you that areas in the low socioeconomic communities, people who are underprivileged do not get ultrasound, and ultrasound is very essential in supporting the mother in terms of delivery. And even with the advent of AI, we are looking at ways in which we can come in with task shifting and everything. But today, I would like to take you through the role of point of care ultrasound in the prevention and management of postpartum hemorrhage. And this one is a scope review. We are looking for evidence that we can use from all the research that you have done out there and published. Is there evidence that we can pick and support our quest to support the fact that we really need point of care ultrasound in PPH prevention? And the statistics have it. We remember that PPH is the #1 cause of maternal mortality globally, and about 140,000 deaths globally according to WHO 2021. And we know that 80% of these cases are attributed to mainly the uterine tone. Remember the 4 T's, eh? So, and out of these, 75% of these deaths are actually preventable. So, as I've already said, I've already highlighted the problem is that PPH remains the #1 cause of maternal mortality, and we need to intervene. And we are looking for POCUS to help us in the intervention. And why POCUS? Because point of care ultrasound in itself, let me define it, the care, it's actually an intervention where the person who is performing the sonography is the person who is giving the service. So is it the doctor, is it the nurse, is it the midwife, is the one who is doing this investigation at the bedside without necessarily waiting for imaging services, so that we save time. And this one can actually be begun from the triage area as the mother just comes. The person who is taking the vital signs actually is supposed to be part of the vital signs that are being taken, the point of care ultrasound. And the gap is we are looking for evidence on the POCUS for PPH is actually fragmented across the assessments by bodies, FASO protocols, issues with blood loss quantification, and low resource task shifting literature that I'm going to talk about. So while we did the research to review what has been published there, and we were digging in for evidence that POCUS can be used, we were looking for areas where it can actually be used. So we were to map the scope of the evidence of POCUS, and we found 4 areas. The use of POCUS in uterine assessment and retained product of conception assessment. And we evaluated the FASO protocols, that is the focused assessment scan for obstetrics, for looking for in the hemoperitoneum, looking for blood around the peritoneum. And blood loss quantification, if POCUS can be used in blood loss quantification. And then we are looking for use of POCUS in task shifting in the low and middle income countries. So for diagnosis accuracy of the uterine and retained product of conception, you see that we are looking at the sensitivity. These are the findings that we found. We looked at different things that we can find as a sonographic marker, the biomarkers. So we're looking at echogenic, intrauterine mass. So here is a mass that you see in the, you do a scan on the abdomen, and you're seeing a mass that is echogenic. It's something that looking shiny, yeah? And you want to find out what is this mass in a mother perhaps who we are suspecting to be having excessive bleeding. And then we looked at the evidence for the color Doppler and also the endometrial thickness above 10 millimeters. So in terms of sensitivity, we found that POCAS had 91.5% in identifying echogenic intrauterine mass that is related to be the likely cause. This mass could be anything, could be a retained product of conception, could be the placenta tissue itself, or it could be just clots of blood inside there. And remember that clots inside the clots of blood is an indicator that bleeding obviously is going on. And this clot of blood, you cannot see it because the standard methods of measuring the volumes of blood loss is actually, the blood is collected from outside the reproductive tract, but there's actually some more blood that's already accumulated inside the uterus. So when we look at an echogenic pattern or echogenic picture, the POCAS is giving it a high sensitivity of 91.5. If we use a color Doppler, the sensitivity is good at 85%, but it can't really give us the specificity, because there are a lot of things that can give us a color Doppler flow. Remember, the uterus itself is highly vascularized and there's a lot of flow of blood. So if it is just picking something that the blood is flowing highly, that's the color Doppler, yes, it will pick it to the sensitivity of 85, but it is not specific. But you see that the POCAS is giving us a very good value there. Then endometrial thickness of about 10 millimeters. We usually expect that endometrial thickness, it becomes less than 1 centimeter after delivery. And so we say perhaps it could also be a marker. But it was peaking at 66.7. And remember, endometrial thickness itself can be due to other things. So it can be due to endometritis itself. It could be other growth that is taking place on the uterus. So we find that of these three biological markers, POCAS is giving us a very good sensitivity of 91.5%, which is the best predictor of PPH, and also high sensitivity. So when we go to blood loss quantification by ultrasound, can we use POCAS for quantification of blood loss? And I just want to mention here that the blood loss that we measure with the drapes, the standard calibrated drapes, is the blood that has come out of the uterus itself. We're actually missing something inside the uterus there. And the POCAS here is not going to give you in terms of millimeters how much blood we have lost, but it's going to give you a clue or a picture of something that is going on inside that uterus. So in the statistics that we found when we dug deeper on findings, Isini et al. 2020 did a prospective study of between 30 to 45 minutes postpartum. And the finding is that we went through how they found this. That the different parts of that uterus, we have the body, we have the fundus, the isthmus, and then we have the cervix down there. Immediately after delivery, we expect that there's contraction. And when there's contraction, we expect that after some time, all the retained product from conception of the placenta goes out, and then the isthmus is supposed to narrow. Remember, the isthmus is the narrow, is like a bottleneck, is the narrow part of the uterus. But imagine here, the mother is bleeding, and you are finding the isthmus diameter still remains persistently high. So we put it, they put a cutoff at 2.4 centimeters. And these centimeters, let me say how they arrived at it. They said, if we take diameters, different diameters for many patients, the diameters or the cross-sectional diameter of the sagittal diameter of the isthmus, different ones, we'll say start from 1.4, 1.6, 1.8 to 2.4. And then we look at outcome, we find that those who had the isthmus sagittal diameter below 2.4 centimeters did not have PPH at the end. When you follow them, they didn't have. But those who had isthmus sagittal diameter at 2.4 or more, which means it's still large, and there's something that is making it large. And what is making it that diameter to still be large, there's something in the body there. And maybe it's some retained product of consumption. There's maybe a lot of clot there, applying pressure, and therefore it's still large. And this one is likely, when you look at the aftermath, when you look at the patient, you realize that this patient has actually lost a lot of blood, which you diagnose as PPH. So when they took these cross sections and plotted them in a curve, in a linear curve, and they found the area under the curve. That's what you're seeing there, the AUC. The AUC that is predicting, if you relate, for example, with the 2.4 centimeters and above of the isthmus diameter, it was 0.99% predicting, 0.99 or 99 out of 100 prediction of PPH. It was that accurate, that any enlarging diameter above that 2.4 centimeters, and you plot all that 2.4 centimeters and above, was likely, 99% likely to be PPH. This was the finding according to the Sini et al. In 2020. That is the summary of all that. That is this there. That is there. And then they use regression models. So when you plot that and you do the statistics method, when you plot that and you find the correlation, when you do correlation between, for example, I take one of the parameters. If I'm using, for example, I'm measuring the isthmus using the ultrasound, the point of care ultrasound, and I'm measuring the sagittal diameter of different women and finding 2.4 centimeters and above, and I relate with the true values, for example, of hemoglobin. Maybe after 45 centimeters, 45 minutes, or 45 minutes up to 1 hour. When you measure the hemoglobin and you relate with the value that you found with the diameter of 2.4 centimeters, there was a direct correlation. And that's why what you're seeing there, the R squared was 0.59. So with this, there was actually evidence that, yes, we cannot measure in terms of millimeters the volume of blood that is lost, but we can actually use the ultrasound to use the biomarkers to accurately predict for us as a predictor that we're actually dealing with PPH. Then we looked at FASO protocol on occult hemoperitoneum. And the FASO, I've already defined that these are focused assessment sonography for obstetrics. It's just a modification of the FAST, the one that's used by surgeons, the focused abdominal scans for trauma. So here, when you use POCUS and you look at anatomical spaces, mainly we explored 5 anatomical spaces, and these ones are intrauterine cavity diameter, porch of Douglas, Morrison's porch, that is between the liver and the kidneys, and there's splenorenal space and the inferior vena cava diameter. When you use this, when you do point of care ultrasound measuring or finding fluid in these spaces, it actually helps to explain for you something that is very significant. Let me give you a case scenario. A mother has delivered, and the uterus has contracted. Well, maybe it was a cesarean section. So you've done your stitches well, you've closed the uterus very well, you've placed it back there, you've sutured in layers, and you've already take care of the mother. There's no pervaginal bleeding. There's no pervaginal bleeding now, or very minimal. But vital signs are showing that the mother is deteriorating, right? Yeah. So most likely there's a bleeder somewhere. There must be a bleeder somewhere. So using FASO protocols, we scan through these spaces, and the case there we are given there of a mother who underwent through this process and was seen to be going into shock. So POCUS was used to check these spaces, and they actually found fluid in any of these spaces, and an immediate intervention was taken without waiting, and they helped to save the mother. So this one can just show you how POCUS is going to be very important in not just estimating the volume, but also looking for bleeder elsewhere, maybe from a ruptured uterus. Perhaps we give excess medicines, cause a rupture, and then the bleeder is somewhere there. Or maybe in the course of suturing, when I'm doing a surgery and I cut an intestine or I cut a blood vessel elsewhere that is not in the uterus, and now there's bleeding going on inside there. We can actually use a point of care ultrasound to get this. On POCUS in low, I'm just finishing. This is my last slide. I'm sorry for keeping you here. POCUS in low and middle income countries. So we are trying to see, can we now use POCUS in the low and middle income countries who have one main problem? The problem is there are facilities, dispensaries, level 2, 3, 4 there, level 2 and 3. Midwives are there, but they don't have an ultrasound. Most sonographers are concentrated in urban areas. That's true, right? Yes, sonographers, most people who have done ultrasound are concentrated in urban areas because, of course, they need to make a living. So they come to look for a living here. How about people in the rural areas and areas with low socioeconomic settings? Can we use point of care ultrasound to intervene there by training the primary caregivers? And we train them only on basics. Look for example, the number of fetus who are there. What is the lie? Basics only. So that we can refer early. These ones we don't deliver here. This one let's refer. This one we can take care of. This one. You see. So we are looking at things like task shifting. That's what I'm calling task shifting. And task shifting means we are moving the burden from only the person who is doing the sonography to the first care sonographers to help us to, we equip them, the clinical officers, the nurses, the midwives, to carry out these investigations. And the outcome was, it was terrific. All reported improved diagnosis accuracy and clinical examination. So finally, these are the findings. You can see the findings. My point is I've already passed across because of time, but we know that task shifting is going to help us in diagnosing and referral and also triaging. Portable handheld devices are suitable for primary care, and we just need to invest there. We found barriers. The barriers are the high cost of face-to-face training, poor internet connectivity, unstable electricity, lack of standardized training. This one, standardized training, we already have a protocol in Kenya, and we are already enrolling it in our universities. And the curriculum, the ministry has done a good job in terms of this. And then the limited evidence on long-term skill retention. With this, I want to say thank you very much. These are my references. Thank you very much. Thank you.
Taken 3 people's time. So, but we appreciate the illumination on the use of POCUS in diagnosing PPH. So our next presenter is Oyo Polycarp. So Polycarp, kindly get yourself on the stage.
Good morning. It's a good, I think my slide is very heavy. It could not fit the normal the normal computer. Otherwise, I'm Polycarp Oyo. I work with ICRHK. and I'm very pleased and at the same time humbled to be here today for this wonderful summit to discuss about PPH. So I'll be sharing a bit about our key achievements in scaling up heat-stable carbetocin and tranexamic acid for postpartum hemorrhage prevention and management across 7 counties in Kenya, and just looking at the lessons that you are able to gather and pick. So this has been repeated by various speakers, so I'll not really want to labor so much about it in terms of where we are and the burden of postpartum hemorrhage. However, it is good to note that we still have several challenges when it comes to commodity access and also gaps in clinical preparedness, and especially when you talk about immediate response and procedures for detection and preventing, detection and managing of postpartum hemorrhage. And there are 2 drugs that are very key within that cycle, and one of them is heat-stable carbetocin that is used for the prevention of postpartum hemorrhage, and TXA used in the treatment as part of the emotive care bundle. So ICRHK had a strategy, and one of the strategy was to strengthen clinical capacity through mentorship. We also advocated for the use of HSC and TXA across the 7 counties that have been listed, that is Kilifi, Kiambu, Nairobi, Nakuru, Kakamega, Kitui, and Kisumu. And this was in a bid to just improve the logistical system around it. So we did sort of a descriptive retrospective review of routine program and commodity data, where we looked at information from KHIS, and also we reviewed data from the ILMIS, that is the Integrated Logistical Management Information System within the country. And some of the indicators we were looking at was what was the uptake of HSC and TXA doses that we monitored during our active implementation in the counties, and what was the the procurement, how was it during that period. And so we were looking at the cumulative track. We were tracking cumulatively the procurement of both the drugs as in a bid to see if our advocacy efforts were actually moving on well. So let's look a bit on the results. So the whole 7 counties, when we entered, or rather when we started our implementation within that, they had not optimized the use of both HSC and TX. And there were gaps in terms of how do we prevent postpartum hemorrhage and how do we manage PPH. You'd find the emotive care bundle, the fidelity towards it was not so much adhered to, because we'll still, yes, we'll call it an emotive, but there are components of the emotive that were not there, like especially TXA is always overlooked because of gaps, of course, in terms of accessing it and other things, and also for the heat-stable carbetocin. So when we began, we recorded substantial improvements in the uptake and procurement of both drugs following mentorship and advocacy. So we were not only focusing on the healthcare providers, but we were also bringing on board the pharmacists, the reproductive health coordinator, so everybody within the supply chain system that we felt will be useful for this cause, we were bringing that. And as you can see, when we began the interventions, and the time we finished, I think that should be, I don't know, the orange or the red bar, we sort of like doubled in terms of across the counties cumulatively. We doubled the use of these commodities. And you can see for heat-stable carbetocin, even went much more higher, because one of the things that the healthcare provider said, this drug is doing wonders. We no longer have to clean our maternity as we used to, because there is no blood, there are no stains. Others will call it kausha. So it does a lot of wonders. And the other thing that we noted during the uptake is there was a bit of hoarding of this commodity. So most of healthcare workers will hold it over the weekend to use it for the weekends and public holidays, because nobody wanted to experience a PPH over the weekend. And in some facilities that I will not want to mention, there are doctors who only, limited it to the use for cesarean section, because they felt this drug is doing well, so we don't want to experience a PPH while you are doing a CS. So our role was to, create that opportunity that this commodity can also be used at the maternity. And we made it clear that it is not only for the high-risk women, but every woman should actually benefit from heat-stable carbetocin, because you cannot tell when and how postpartum hemorrhage will happen. A bit of success stories, and Kiambu, I know, has been on the news, especially Kiambu Level 5 Hospital, sustaining the gains to date. Also, Kilifi County Referral Hospital and facilities within Kilifi, after the uptake, they were able to see a reduction in postpartum hemorrhage, and specifically mothers who are progressing to severe PPH. And within that, we saw facilities taking up their own funding to even procure this commodity. And to us, that was a major and a huge win. So it means you only need to create that opportunity and awareness for this commodity. And some of the testimonials we received from the facilities after they began using heat-stable carbetocin was that women were constantly seeking care. There was a lot of confidence now to the community. If you have a facility that is always on the news for maternal mortality, and then suddenly there is no news, so everyone will want to go there and understand, if I go and deliver in this facility, I'm sure I will walk out alive. So that is the confidence you want to create in the community. There was also motivation across the healthcare providers. Oxytocin, as we know, has got a lot of challenges other than the heat, we call the cold chain challenges, also the quality issues, because you'll end up giving a lot of doses of oxytocin, or you give up a dose of oxytocin, you administer, but still you end up with a very severe case of PPH. But with the use of HSC, the healthcare providers became more motivated, because one of the reasons why we do the active management of the third stage of labor is to prevent one of the issues, to prevent postpartum hemorrhage. So when you're able to administer that and you see it's actually working, then that's a very good step. So a lot of motivation, respectful maternity care, and greater preparedness. Everybody would love to see a delivery that is clean. So when your delivery is all and the delivery room cannot be accessed, it becomes a bit of a challenge to that. So I think in terms of our conclusion for today, there is need for conducting mentorship and also structured advocacy. We need to speak to the people that are involved. In most of the counties, it's the county pharmacist, we realize, has the final say in what is actually approved. Because you tell them here, we need heat-stable carbetocin, it's 95 Kenya shillings. And there is this drug called oxytocin that is, I think, about 20 to 30 shillings. So which one do you think they will choose? Of course, they will say we don't have money, we'll go for the oxytocin. But then we brought them on board and we made sure they understood the issues, the elements about the cost and the price. So what is the cost? What is the cost element versus the price element between the two? And they were able to understand. When you use heat-stable carbetocin, you end up saving a lot of money as opposed when you are using the oxytocin. That is special, of course, one that has issues that I've been able to speak about. The other issues, there is also need to continue with capacity building, continuous capacity building, drills, mentorship. We need to support healthcare providers and also to strengthen our supply chain systems through accurate forecasting and supply planning. And also, it's good to always motivate healthcare providers. At times, they go through a lot. We only need to, to find ways of motivating them so that they can be able to offer the kind of services they required. I've been able to speak about this, so I'll not labor it. They also need to look at our data for advocacy. So we were able to produce data and show these women were received heat-stable carbetocin. These women were managed through the emotive care bundle. This group received the oxytocin, and these were the outcome for that. So as I conclude, a bit of pictorials from the work that you are able to do, but one that I think makes it tops up, we were able to celebrate a small gain. And one of them, and also I'm glad I can see some of the partners in Kilifi. I can see Liz there and Yes from Uzazi Salama. So we said, we are giving you, a challenge. You are a facility that does not miss a maternal mortality in a month. So if you can sustain at least for 1 month, just try so that you don't have any death. And they took up that challenge. And within 1 month, we celebrated. We just cut a very simple cake, and we did that. And surprisingly, they were able to continue with that, sustaining that for around 7 months. And to me, that was a very big win. So it means we just need to award and reinforce. It doesn't mean you don't have to give something that is huge, but you need to celebrate. And this was a celebration because we didn't have any mother dying in 1 month. You know, it might seem very small, but just one statistic, it's a human life, and it's got a ripple effect across. So if you see everyone dancing in the maternity and the labor ward, it means every life saved means a lot to us. And so that is one thing we were able to do. And last but not least, we ensure that all the 7 counties, we donated the mannequins and the humanistic models for continuous learning and drills and mentorship across, and to sustain that even beyond when you are not there. And that is happening. So these are at the maternity level. They are used for practice, the mama and the neonatalists, for continuous learning. So thank you so much.
So much, Oyo, for the presentation. So I want to call upon the next 2 presenters kindly, 5 minutes strictly. I hope you received memos. So 5 minutes strictly so that we can have our break kindly. Thank you. So our next presenter is Amina Ibrahim, courtesy of Ferring. So she'll introduce herself better in her own words. Thank you so much.
Okay, good morning, everyone. My name is Amina Ibrahim. I coordinate reproductive health, immunization, and referral in Likoni Sub-County, in Mombasa County, a member of Midwife Association of Kenya, where I coordinate the association activity in the Coast region. So I'm here to share our experience with the heat-stable carbetocin in reducing the postpartum hemorrhage in Likoni Sub-County Hospital. So we all know that postpartum hemorrhage remains one of the leading causes of maternal morbidity and mortality, making its prevention a critical focus in improving maternal outcomes. So the problem is, in the year 2024-2025, we recorded at 73 cases of PPH, which was a burden on the staff in relation to the acute shortage. So the intervention in 2025, we were introduced to the heat-stable carbetocin for routine prevention of PPH. The rollout was not complex. We did CMEs, webinars, and on-job mentorship. I remember Dr. Jalango came all the way to Mombasa, going out to different sub-counties and crossing the ferry to Likoni to sensitize us on the heat-stable carbetocin. Then we procured via KEMSA with no special allocation. So when you look at we compared the cases of PPH from 2024-2025 and the year 2025-26, there was a reduction of 53% with no maternal death due to PPH. So you can see the trend, how the PPH cases came down when we introduced heat-stable carbetocin. The impact was striking. Our PPH numbers shifted immediately, and more importantly, the improvement held steady over time. So we hope in future we are going to stand here to talk about the zero PPH. So feasibility and cost, it is a single dose, ready to use formulation, easy to train. through the CMEs and webinars and integrated into the normal KEMSA procurement. So the price reduction enabled consistent purchase. So the facility moved from ration drug to become a routine drug, and there was indirect saving due to fewer complications. Acceptability part of it was rapidly accepted by the maternity staffs, both the midwife and the doctors, because of the simple administration during busy shift. So the buy-in grew as complication reduced. So the challenge is the KEMSA stockouts are our main risk, although we are working on that, buying from other suppliers, and then interruptions threaten consistent and gains. So this is a voice note, a quote from one of the midwives in the maternity, where I quote, she said, "It is easier to use because it does not require cold chain, not kept in the fridge. You can put it in your tray beside the delivery bed, and when the baby is out, you give it within 1 minute. It can be tricky to get an assistant to give you the oxytocin within 1 minute, but with stable carbetocin, it is easier." So in conclusion, stable carbetocin has proven to be feasible, acceptable, effective, and cost-saving. It was easy to introduce and embraced by the teams, leading to 53% reduction of the PPH cases. So the next step is ensuring reliable supply to protect these gains. We acknowledge the Department of Health, Mombasa County, Likoni Sub-County Hospital, the Ferring Pharmaceutical, KEMSA, Jacaranda Health, and Clinton Health for their mentorship and training on EMOC. So this is the photos of the PPH run in Mombasa County, which we joined the other counties in creating awareness on PPH. There was blood drive which was done, and also we created awareness through local radio stations during that day. Thank you. That is the end of my presentation.
Thank you. Thank you so much, Amina, for the lovely presentation and being quite timely. And thank you so much. I hope the next one will be the same. And I love the enthusiasm of zero rating PPH. I hope that can be the voice of everyone. Let's clap for her again. Juma. Yeah. So our next presenter again is Juma, who is also presenting the experiences. And Juma, kindly introduce yourself. Thank you. And 5 minutes, right? Thank you.
Good morning to all. I'm Dr. Juma Steve. I'm an ops gain in Turkana County, the largest county in Kenya, if not after one. We are number one or number two. So I'm here to give I'm here to give an account of our story concerning PPH. I won't give anything different from the introduction. We all accept that it's a leading, among the leading challenges facing our women who giving birth in our facilities. Just like many other counties, PPH-related maternal deaths is a really big concern, and we all aim to improve. A small data in 2014, Turkana County was the third leading, the worst among the third leading counties in maternal mortalities related to PPH. We had 1594 maternal deaths per 100,000 live births in 2014. This has since then reduced to 381 as of last year, still higher than the national rate. We are doing something really much hard to sort this, but you can see there is tremendous dramatic improvement on this. So as of Turkana, I'll not speak for other counties. Those are our contributors. PPH leading to deaths. We're still struggling with the hypertensive disorders of pregnancies, sepsis, obstructed labor, compounding unsafe abortions. What is compounding these, which is specific to Turkana County? We have long distance to access health facilities, delayed referrals, limited access to blood transfusion services, and because of our culture there, we have low utilization of both antenatal care and postnatal care services, and especially in those villages which are hard to reach. We border 3 countries, that is Ethiopia, Uganda, and South Sudan. So as you can see from that picture, we have challenges with transport. So in 2024, early part of this, we made a decision to bring in a drug which was initially not accessible to us, and this was heat-stable carbetocin. And why we wanted this, we wanted a drug which was going to be easy to administer, going to withstand the heat challenges in Turkana. People say Mombasa and coast is hot. Please, I invite you to Turkana. We normally do temperatures of 42, and that's the norm. So we wanted a drug which is going to withstand this. You can see the challenges we were having with oxytocin. All our mothers were bleeding because the heat, the cold chain was interfered with. Those long distance travel due to referrals was still a challenge. Remote dispensaries, health centers, and Turkana as a county, we're still struggling with electricity supplies, nomadic population, difficult referral systems. So why was this specifically good to us, that we didn't need the cold chain anymore? We had reliable medicine quality despite the temperatures, easy to reach the last level facility, and better preparedness in the remote maternity units. So since 23 to 26 years, we've had a good or remarkable decrease in trends of postpartum related mortalities. That figure there is it's divided. The color which is blue presents the total numbers of postpartum reported cases. The color which is orange present specifically due to atony. Green, is that green? Yes. Green, those due to cervical tear. So yes, we still get postpartum hemorrhage, but the numbers due to atony, which carbetocin has come in to improve, are dramatically reduced. We're still getting cervical tears, we're still getting retained placentas, uterine ruptures, but the one specific which has been really reduced since 2023 to 2026 is atony. We've had a bit of implementation challenges. Initially, we had issues with pricing, which since then have improved since KEMSA came to help us get the drug. Procurement, those who will be dealing with the counties, you know how the push and pull convincing county pharmacies to get you this. Staff orientation. I remember till early this year, we're still doing CMEs even to our anesthetists on how to administer these drugs. And now we've pushed the drug to even level 2 facilities in Turkana counties. So imagine if at level 4 where I am, we're struggling with how to administer this. I'm imagining what's happening on the very far end. So we're still struggling with this. Sustainable financing and continuous commodity availability, we still struggle with stockouts like any other. Areas we aim to improve on, we aim to improve all maternity staffs on how to handle, prevent postpartum hemorrhage and administer these drugs. Update facility protocols. Still a big percentage are okay with oxytocin and refusing to change. They think they've had it all with oxytocin, and this new product still is not very easy to convince them to move to. Continuous supply, at times we get stockouts, so we're aiming to get more stock so that we harmonize this, we don't get this. We still training almost all our maternity staffs on EMONC across the county. We've had around 4 trainings this year, and make sure that it reaches the lowest level of facility in the county. So we've had an impact. We've had reduced cases of PPH due to atony. And this has reduced, you can see the figure, they are 90% in 2 years. We still have these PPHs, but not to atony. And whenever I receive a referral due to PPH, I always ask first, was that carbetocin given? So I think the noise has been so much that everybody don't want to refer before ensuring it was given. So we've had fewer maternal deaths, improved maternity care, reduced blood loss. We no longer rush to our lab to in panic because we need blood. I always say that whenever maternity needs blood, it is always in emergency. So I always argue when I'm told that blood will go to the pediatric unit. I'll have a very stable patient, but when I need blood, I need blood. I don't have 2 hours to need this blood. So we have also reduced need for refrigeration and reduced referrals. So just as that scholar Winston Churchill says that to improve is to change, and to be perfect is to change often. We've seen great improvement in our county, and we aim to continue improving. Thank you. I'm not a Turkana by birth, but that's how we would say it in Turkana. Thank you.
Okay. Thank you. Well done, Dr. Juma, for the amazing work you're doing in Turkana. And now, I want to profusely apologize that we are eating into your break time, but I would like at least 2 questions, just 2 questions. The other things we'll discuss as we take our tea. 2 questions from morning discussions.
Thank you. Thank you for all the presenters. Wonderful presentations. To my brother from East Africa, from Uganda, I loved the presentation, and especially the multidisciplinary bit. Perhaps a suggestion that you might want to consider is if there are ways that you could embed non-technical skills training in the simulation training. I think that if you look at the evidence, you may actually get to see significant improvements. And one question would be, you mentioned low dose, high frequency training. So I'm just wondering about what high frequency is in terms of how often, because from experience I've seen that it's all good to have a wonderful training, take guys for a workshop, buy them tea, but in terms of sustainability, I think it does help to have it regular. Like in our facility now, we usually have every fortnight multidisciplinary skill sessions. So I'd love to hear what high frequency is. The brother from Nigeria, lovely presentation. I think if there's one thing I've taken away, I hope I've not massacred your quote, but conversations about Africa should be convened and discussed in Africa by Africans. Well done. Thank you.
Mm-hmm. Thank you. Thank you so much. Any other question? Yes.
Yeah, thank you so much for the presentation. I have maybe 2 questions or comments. I'll start with, as he's called, the brother from Nigeria. Nigeria works in a very difficult health ecosystem where the federal states are almost like kingdoms. So how do you manage, and I think it could be a learning lesson from Kenya, how do you manage with your very high population, how do you manage to get buy-in from each federal state so that you can move together as a country? The second one is for Dr. Juma, Turkana. Good work you're doing there, Dr. Juma. I wished to hear about the cultural influences that determine outcomes in maternal health, because I think Turkana is heavily, heavily influenced by what the people believe and how they, and how that determines their social norms. So those are my 2 questions. All presentations were wonderful.
Thank you. Thank you so much. I need to shift to the other side. Yes, Prof, do you have a microphone?
And do you have a question? You are okay. Good morning. My name is Julius Ogengo, a conference coordinator, and I have a question for several of you and some comments. Dr. Kayondo, comment, question. Your curriculum for the PPH run and the curriculum for the trainings you have, and a comment on their sustainability. Florida Sena from Narok. Excellent. You mentioned a key issue that was predisposing anemia, which has been a big thing we've all been talking about. I thought you would be in a good position to say something about what you are doing about the patient blood management in relation to that upstream matter. And so that I don't have to name anybody, all of you who are studying postpartum hemorrhage, you are studying it in your facilities. I advise that you also look at postpartum hemorrhage that you don't see in the hospital. I will share one statement that will trigger you. Of the death, maternal death that occur at home, outside the health facility, PPH remains the leading, but the mechanism is different. It is not atony. It is trauma. Gynecologists to think about that. A quick look at corona registries in Nairobi indicate that the PPH that you see among those who don't come to hospital would be caused by another pattern. And even the cause of maternal death are different. So as you do so, and it's not that difficult, you can do verbal autopsies and you collect very good data. Now, those who talked about mentorship, the question to you is sustainability of your mentorship program and the scalability of it. Dr. Gulavi, excellent. I did not see the quality assurance factor in that matter of flattening that curve. Flattening the hierarchy definitely works, even in other administrative scenarios, but you put in how do you assure the quality? How do you monitor that quality assurance? Dr. Oyugi, excellent. I saw the things you for in that point of care. You mentioned anatomy, so certainly you touched me. Just a caution, look beyond that abdomen. Look also in the chest. Look also in the lower limb. Some of that blood could be in the thigh, and some of it will be in the chest. And now, Juma, my question was asked for you, but I add, apart from socio-cultural, have you looked at the environmental and climate change factors? Because Turkana is vulnerable to that score. No particular answer, but if anybody has a comment, but those are things that I thought I mentioned. Thank you.
Thank you. Oh, thanks. Just a quick one for Dr. Kulavi and Prof. Flattening the hierarchies, it's a very interesting concept and maybe something you could look into. There was an implementation research that was done on establishing a network of care in Makueni, and it's done wonders in terms of improving trust and communication among the healthcare workforce. So it might help to feed into the work that you're doing and the study that you're doing. So just a tip. Yeah, but otherwise excellent.
Thank you. Thank you so much. I don't know where to begin. Maybe with our honorable Ugandan doctor.
Thank you very much. Honorable is really interesting. But high frequency, how often? It's weekly. But it doesn't have to be many hours. They can commit an hour to 2 and just touch a small component of PPH management. They have a platform, the practice coordinators, they have a platform where they should report weekly with evidence of what has been done. So it means they will have to do something. But what is very interesting in Uganda, and I don't know if anyone else has adopted it, is a lot of this leadership is being moved away from us, the doctors, and given to the midwives. And what I've seen is the midwives are committed. When they will say, I will do this, they do it. Okay. Prof, sustainability of the curriculum. Yeah, I understand your worries, but starting on a light point is PPH, interestingly, has very ready funding. It's always there as compared to other areas of maternal health. However, I will say that this is promoted through the local maternity and neonatal systems, and these don't really need a lot of resources to keep running, because once you have the region organized, they will do this continuous mentorship and support to the districts and down to the facilities. So that is one area of sustainability. Two, there are simulation labs established at the regional facilities, but also in high volume facilities, even if it is district hospitals. So it means if they want to build skills now and again, they can use these simulation labs. Finally, the practice coordinators are at the facility level, meaning even if there are no resources, there will be support. The trainings that are done in hotels and simulation labs at the regional facilities are one-offs and maybe once in a while refreshers, but these practice coordinators are within the facilities. And the governance of the facilities is asked to actually take away some roles from them so that they can create some time for this additional role. Thank you so much.
All right. Thank you so much, sir, for acknowledging your presentation. So the question on how health is coordinated in Nigeria now, I think, like you rightly pointed out, for the longest time, we had to support scale-up efforts on a state-by-state basis, which took a very long time, and of course, different contexts. But since 2024, under the leadership of Honorable Minister Pate, Nigeria's health ministry has been under a significant reform using a sector-wide approach. That then means in health, it's one conversation, one plan, one result. And the flagship initiative is called the National Health Sector Renewal Initiative and Investments. So through this, all states had to sign a compact that they would commit to the one plan, one discussion. What it also means is that every donor investing in Nigeria now has to go through the Federal Ministry of Health, key into the plans, the ongoing work, and then ensure it's complementary. And I think for maternal health specifically, we have a flagship project called MAMI, which first did the thorough job of mapping the most LGA, the LGAs contributing the most maternal mortalities, and concentrating investments, whether that's health worker capacity building, health worker recruitment, product supply, to those places, and hoping that over time we would see results. So that's how the reform has been playing out. Thank you.
Thank you. Thank you so much. Political commitment.
So thank you so much. This is Florida Sena from Transmara Sub-County. Just to respond on the issue which has been raised about anemia that came in as one of the predisposing factor, which made the rise of the 5 cases of PPH. We noted the issue of iron deficiency, and what we've done at the community, we health educate our mothers on early ANC visits, because most of our mothers come at third trimester. So most of them don't get IFAS, and they also don't get education on nutritional diet. So we've really given some strategies so that we can have the message back home for our clients. For the blood transfusion, unfortunately, our level 4 facility is not yet fully operational on blood transfusion, so we refer our clients to a nearby level 4 facility. I think that is all, and thank you.
Thank you. Thank you so much.
If you talk about Turkana County and culture, I'll bring to attention that it's among the deeply culturally rooted communities we still have in Kenya. So we've initially had challenges with mothers going to labor at home and trusting the traditional birth attendants. So there was an initial initiative that any traditional birth attendant would accompany a mother in labor would be given a token. And this really increased the number of mothers who are now delivering in the hospital and reduced home deliveries. The program ran for some time, then it died off. We came up with a new program that all deliveries would be free. Also, we saw a very good rise in numbers. Then came SHA. Now this is my biggest headache. And the worst part is they did IDs. That's my biggest headache, because probably 30% don't have IDs, but they need to deliver. So when they come to the hospital, they need to be registered. Now we are going to Taifa Care, which again, at any point, I have like 15 mothers who can't go home because the person at the SHA office can't release them. So you have to again go intervene. Also, to try and encourage them to deliver in the hospital, we introduced something known as a bathing stool. Have you ever heard of a bathing stool?
Yes.
So only I think it's only available in Turkana.
Turkana.
So we give them the option. Do you want to deliver on the bathing stool or this new findings that once they come to the hospital, they actually prefer delivering on our beds, unlike what we thought that they'll prefer continuing the bathing stool. So we still give that option to them. So really giving us a bit of edge to try convince them that we can still have our culture and deliver safely in the hospital. Second question is environmental climatic factors in Turkana County affecting us. For sure, this is a purely arid, semi-arid location. We have vast challenges coming with this, and it's obviously affecting us, our access to maternity, access to quality services. So it's a problem we know. We're hoping we will catch up. Thank you.
Thank you very much to all the speakers. I've been asked to give a synopsis, and I'll give a synopsis and maybe a few comments. Number one is to really appreciate those who presented. And I think it's come out very clearly, the evidence on heat-stable carbetocin vis-a-vis oxytocin in our setup. The fact that we have heat to contend with, cold chain issues, and the results speak for themselves. I think we can all attest to that. Where I've been working, they clearly call it kausha, dry up. There's no more cleaning that used to be there with a lot of blood loss. Flattening the hierarchy, it was per excellence. That just speaks to team culture. A lot of people talk about teamwork. I'm a firm believer of team culture, which then marries very well with Simon, where you're talking about the interprofessional collaboration. It's no longer about the midwife or the gynecologist. In fact, the gyna, let's be honest, we see 1 in 10 patients. And really, we should be reserved for complications. majority frontline is the midwife. I don't know where my midwife president is seated. Where is she? Midwife. Okay, the vice is here. You should be standing. We recognize this right from FIGO, where we said the leadership has to change. When we were doing the consolidated guidelines for PPH, it was FIGO, ICM, WHO. I personally am a firm believer in the midwife for the simple reason, my own story. When I was doing my very first cesarean section, my senior was called, he was drunk, and he collapsed. And we said, resuscitate. And I looked across the table and I asked the midwife, you've been in this maternity unit for over 25 years. Show me the way. So when I say I believe in the midwife, even when I'm examining students, I ask for the midwife's opinion because it matters. The other thing is the issue of what my colleague, my senior colleague and professor has brought up. Anemia, anemia, anemia. It's our African elephant. And I don't think it's just nutrition. We have blood issues, sickle cell, G6PD, thalassemias, whatever. But beyond that, are we really carrying the message of nutrition even before she becomes pregnant? So pre-conceptual care, it doesn't exist. And I think we need to really push into that direction to have the woman primed to be at her best, so that that incubation period of 9 months for the baby is in an environment that is sound. That's homework for all of us, addressing anemia. And when you talk anemia, please do not forget the woman is also the agriculturalist in every home and the feeder of everyone in every home. So you are what you eat. That's a paper I want you to all go and read. It's a FIGO paper. Yeah, think nutrition first. That's the title of that paper. Okay? But more so, one health, environment, human health, animal health. Those go together. Last is culture. My colleague from Turkana. It is so, so important. My other colleague from Narok. In Narok, there was something a few years ago we did where we even asked the tourism industry to work together with us. I don't know where my Narok lady is seated. Where is she? Excellent. You know Aitong Health Center? You know Olchoro Health Center? I've been there. And I've been there with people with a very different dispensation. They were coming in as tourists, and I said, why don't we hold a medical camp? And we sang Maasai songs to attract people to come to the facility. You may use that in Turkana. Go to the culture and the arts. 1, for health messaging. 2, for attracting them to health facilities. And 3 is to really have the conversation with SHA. Where we have vulnerable populations, what can we do differently? Lastly, private sector. And this I'm addressing now my good friend Obimbo. What is the real link between public-private health sector? Because the private sector has got the element of market intelligence and social enterprise. When we keep hearing we're running out of drugs, KEMSA is not able to supply, this is within the public system. What can the private sector onboard for us? And I think their omission, even my good friend who's standing there, their omission in these conversations, we really need to have a look at it. Because it's a core group we're not really pulling together with. And we've got opportunities in which we should exploit the potential they present to us. Whether it's pharma, whether it's transport, whether it's agriculture, whether it's educative piece, whether it's data. My very last is in the clinical setting. As we do the interprofessional collaboration, there is a group of people we still haven't brought to the center. That's the data clerks. The people who really are supposed to be core for your advocacy message, the one you're talking about, smart advocacy. They have to be part of us one, it'll improve our data collection. Two, it will have us audit and make them really appreciate why is it we keep asking them for the KPIs. Because right now they just think we're bombarding them with much more work. And thirdly, is bringing on board the health economic conversation. As a leader, I would be asked by the governor, what's the value proposition? Why should I invest in heat-stable carbetocin and tranexamic acid as opposed to oxytocin? So what's our role as health providers in the health economics conversation? And this is something I think that we need to cascade all the way up to the AU to be able to get Africans access quality care, but also have economic sense to what we are putting in place. I'm a firm believer the woman has more than reproduction to offer. If given a chance, her productivity in nations of Africa would be par excellence. Thank you.
Thank you. Thank you so much, Professor, for the synopsis. And now we have earned our tea, but before we go for the tea, kindly all the presenters that are coming after tea break to see Professor Kihara here. Then we also need to celebrate the day by having a picture. So, Prof, okay.
Thank you. Thank you. Professor Kihara, come and sit here next to Professor Lucho. Victor, sit there. Next to Moses. Kayondu, come and sit here next to FIGO President Emeritus. Now, those of you sitting in the flanks, find space in the center.
There is a president you invited who was saying he hasn't